Good evening, everybody. And I am Dr. Agam Vora, the Secretary of Academy of Advanced Medical Education from Mumbai. And today we are going to be discussing about the big options for managing COVID-19 infection. Last 6 months taught us various new things. We are going through this unprecedented time. We never thought that a small 100 nanomicron virus would change our lives. And it changed our lives to the extent that probably we are going to stand still. Probably the largest lockdown in the history of global history we witnessed, and the entire country just stopped functioning. We saw probably unbelievable suffering. We saw unbelievable mortality. We learned new terms. We learned about cytokine storms, and we started asking for various tests. We started asking for interleukin-6, and we started asking for LDH, ferritin, whatnot, and God knows, in last 20 years, the kind of test I would have not asked for, I've asked for in last 6 months. Every third day we are asking for this test without knowing how to interpret this results and without knowing what kind of change, therapeutic change it will have in the management. But that's what has happened. We tried every possible thing. We have tried all various antibiotics. We tried all various drugs like Ivermectin. We tried Zinc. We tried vitamin C. Then we tried our old Oseltamivir. And gradually we tried, we got Favipiravir and Remdesivir, and we tried all those medicines. And after 6 months, 7 months, we are still lost. We do not know how to manage these patients. We have various immunomodulators role. We thought BCG probably would give us some protection. We thought MMR would give us some protection. And in India, we were under a false security. We thought earlier that we may not get affected at all because we are probably in the going to the summer. We probably have a better climate and we would not see that. We were proved wrong. We thought we have taken BCG, probably will not be affected. We were proved wrong. We thought probably our hand hygienes are good, and we have a better herd immunity because we take holy bath in Ganga river. Probably 1 crore of us do that at a time. We sit in langar and have food together at a time. Even the smallest event, and we gather in thousands and thousands, and probably that would give us some immunity. Again, we were proved wrong. We thought that probably monsoon and all this virus will be taken care of. Everything is proving wrong, and probably it is the time we talk about what weapons we have to fight this particular disease, and how do we use all this, whatever drugs and whatever understanding we have rationally. Today, for that, we have the excellent panel with us. But before I introduce the panel and the moderator, I have to thank our educational partner, and educational partners are none other than Delcure. Delcure CEO is my close friend, Mr. Akshay Mahapatra. Akshay, I know for last Akshay kitna 10 saal ho gaya na? I know him for a decade.
Yeah,
ye baat alag hai ki every time when I saw him, he had one after the other promotion, and today probably from a very close friend he's become CEO of a company, and I'm still there. But then still, I'm very happy for you, Akshay. I request Pratiksha, the medical team head, to give a formal introduction from the corporate side. Over to you, Pratiksha.
Thank you, Dr. Agam Vora, sir, for the welcome note. Good evening, everyone. Wish you all a very happy Independence Day. Let me share my screen. Yeah. I am Dr. Pratiksha Mainkar, and it is my pleasure to give you all an overview of Delcure Lifesciences, a young, innovative pharmaceutical company. Our vision is to become the most respected, uniquely positioned leading pharmaceutical company in the chosen areas or specialty verticals in India and abroad with distinct value-based characteristics. We believe in a culture of happiness, helpfulness, and truthfulness. We are a group company of Acums, the country's largest formulation manufacturer. It maintains highest quality standards and is approved by global regulatory agencies like WHO GMP, GLP, NAFDAC, ISO, and ANVISA. Our campaign, Honor Your Doctor, strongly condemns violence against doctors and is committed to honor our noble profession. The aim is to increase the trust between the doctor fraternity and the society. With the launch of this campaign in 2017, activities are conducted across the country to reinforce the importance of doctors in our society. Nucleus is an academic platform of Delcure Lifesciences. This campaign includes various initiatives which help in dissemination of knowledge or scientific information across the medical fraternity. Access to healthcare and medicines is every individual's right. And to expand the reach of our medicines, we plan to triple our manpower in the next 2 years. We are presently operating in the therapy areas of nutraceuticals, pain management, respiratory, gastroenterology, diabetic neuropathy, and orthopedics. Going ahead, we plan to bring dermatology, urology, and critical care in our fold. Delcure also wants to be a part of the warrior team to fight against COVID-19, hence the introduction of our COVID-19 management range, which includes immunity boosting products like Delc-Z and Delc Plus, which contains a combination of vital immunity building ingredients like vitamin C, vitamin D, zinc, and amla. Our recent launches include Favipiravir 200 mg tablets under the brand name Favidel and Ivermectin 12 mg tablets under the brand name Tough. It is my honor to introduce our CEO and MD, Mr. Akshay Kumar Mahapatra. He brings with him 26 years of rich pharmaceutical experience, notably in the development and management of strategic opportunities and bringing therapeutic products to the Indian market. He is a leader who believes passion and dedication with knowledge are the only drivers for success and our achievement. With this, I conclude my presentation and let me now again invite Dr. Agam Vora sir to do the further proceedings. Thank you very much.
Thanks, Pratiksha. That is a very nice overview of your company.
Thank you, sir.
Akshay, 26 years? Oh, shit. You're senior than me in industry. Good. I think we move on to the panel discussion, and we have excellent panel here. And all the panelists are very close to my teacher, Professor Director Dr. K.C. Mohanty. Dr. Tada, I met again some 22 years ago with Professor Mohanty for the first time, and when he took me to first trip to Northeast, and since then, probably sir has kept so much of love and affection for us in academy that he is always honored our invitation to be there with us. Dr. Randeep Guleria, thank you very much for joining. Dr. Deepak Talvar, Raja, all Mohanty sir's favorite. So whenever he would design any program, first few names that he would put it down and ask me, confirm their presence, confirm their timing, are these names. So I'm really grateful that you all are here. And the program is moderated by none other than my very close friend, Dr. Ketan Mehta. Ketan is currently the president of Academy of Advanced Medical Education, the platform which we're using. Ketan is a physician par excellence with his special interest in diabetology and cardiology. He is giving his services at Asian Heart Institute, at Raheja Hospital, and at Suchak Hospital. And I'm fortunate that every day morning, my morning starts with, it's coffee with Ketan. So then in the morning, Suchak Hospital, we have our first coffee together, and then our day starts. So whenever we are in town, probably, we meet daily. Ketan has shouldered various responsibilities of various associations, is very active with the Malad Medical Association, very active with IMA, Mumbai West, and probably he has organized various conferences on his own. He is currently in the managing committee of Cardiology Society of India. With that, I hand over the platform to Ketan. Dr. Ketan Mehta, over to you.
Thank you, Agam. A very good evening to all of you. Agam has given a very nice introduction about the subject and topic, and since we have a galaxy of faculty with us, I'm sure you all are going to have a real blast for today's topic. Friend, today we know what we are going to discuss about. One sec, I will just... Yeah. Before we start today's talk, let us wish a happy Independence Day to all of you. Today being the 15th August and a very auspicious day, and obviously on this day we feel proud to be gathering on this subject. And what we are going to discuss is having a panel discussion on treatment options for COVID-19. We all know since last so many months we have been just talking about just one subject, and that is COVID. And when we talk about or when we discuss it, we know the change is the only constant thing in nature, and so is the true when it comes to COVID. Everything goes on changing, right from his treatment modalities, be it at a national level or a state level, the various options which we have seen go on changing. And that is why it reminds me of words from Isaac Newton, that what we know is a drop, what we don't know is an ocean, which is so much true when it comes to COVID-19. And to solve these issues, we have the fantastic panelist with us for today's discussion. In fact, I was just discussing with Agam. I said, you have given me a tough duty. You know, when I have to introduce panelists, there has to be one separate session for introduction of panelists. So that is where it is. So let me start introducing. I may have to go very brief. So excuse me, because by the way, these all faculties do not require any introduction. They are all renowned faculties. Professor Dr. Randeep Guleria, a Padma Shri and a BC Roy awardee. He is the director AIMS at New Delhi. He is a member of the WHO Scientific Advisory Group of Experts. He is a fellow and member of several national and international bodies, including National Academy of Medical Science, International Medical Science Academy, Indian Association of Sarcoidosis, National College of Chest Physicians, Indian Chest Society. Sir has been on an editorial board of number of journals, including Indian Journal of Chest Disease, Lung India, Journal of American Medical Association, Chest. He has published n number of articles in the national as well as international journals. He has been an invited faculty at many forums. So we welcome you, sir, for this interactive panel discussion. Our next panelist is Dr. Deepak Talvar, who is a senior consultant and chairman, Metro Respiratory Center, Pulmonology and Sleep Medicine. He has been a faculty of Academy for Infection Management. He is a member of International Society of Critical Care Medicine, member of European Society of Enteral and Parental Nutrition. He is the instructor for FCCS course. His name has been featured in the Limca Book of Records. So we feel proud, sir. We definitely feel so much proud that you have joined with us. Has various national, international, and research publications to his credit. He has been a faculty member at various national and international conferences such as NAPCon, BronchoCon, Criticon, SleepCon, and of course, HappyCon. Welcome you, sir.
Thank you, Ketan.
Our next panelist is Dr. Rajadhar, who is a director and head of Department of Pulmonology, Fortis Hospital, Kolkata. He is a director research and education for National Allergy, Asthma, Bronchitis Institute, Kolkata. He is the ICS national representative for ERS. He is a governing body member of the Indian Chest Society and also of Indian Academy of Bronchology. He is the joint secretary of Indian Academy of Allergy and also the founder member of Southeast Asian Academy of Sleep Medicine. Of course, he has a large number of publications in various index journal and various abstracts written in various book chapters. He's been a reviewer for American College of Chest Physician meeting, and he is the examiner for the MRCP both in UK and in India. And he is the coordinator for DNB course for last 5 years. We welcome you, sir, for this panel discussion. Our next panelist is Dr. Bamin Tada, who is the Secretary of TB Association of Northeast India, former Director of RRC Northeast based at Guwahati. He was the former advisor Health Northeastern Council based at Shillong. He was joint DHS. He was deputy DHS for Nagaland. He has served at various categories, and I would say he was the one who was offered, or rather he was given a Nobel laureate Mother Teresa's appreciation letter for service to the weaker section of the society. He has also received Arunachal Pradesh State Award Gold Medal in the field of public health. He's also been the recipient of Arunachal Pradesh Best TB Worker Award for 2002, has also received Lifetime Achievement Award from Government of Arunachal Pradesh. He has also received number of orations, including Professor S.N. Tripathi Memorial Oration Award from the NatCon Patna 2013. I know Dr. Bamin Tada again for almost 2 decades. Excellent persons. We welcome you for this panel discussion. And of course, none other than Dr. Agam Vora. He is also the Secretary of Academy of Advanced Medical Education, a senior pulmonologist and chest physician, a very close friend of mine. He is the Assistant Honorary Physician and in charge Department of Chest and TB at R.N. Cooper Municipal General Hospital. He is been the patron of Tuberculosis Association of India. He was the past president of Geriatric Society of India. He is the assistant editor of JAPI, member editorial board of Chest India. He is the governing body member of API, committee member of IMA Mumbai West in the past, and the state coordinator for IMA NTB project. So we welcome all the panelists for this panel discussion. Friends, all of you know the timeline for COVID-19 when the first case, which was presented as an unexplained case of pneumonia in Wuhan in December 2019, and subsequently they started investigating, and then in the 12th January, the novel coronavirus was in 2019 NCO was designated by WHO. In India, the first case which came in light was 31st January, and on 11th February, the nomenclature came about the SARS-CoV-2, which we know and WHO announced as the new disease which has come across the globe. But it took again 1 more month for WHO to declare it as a pandemic, and only on 11th March 2020, the WHO declared that this SARS-CoV-2 virus which is causing these issues has been declared as a pandemic, and on 12th March we had the first mortality in our country which was reported. So this, all of us are aware about it, and we know over a period of time the clinical management protocol which goes on changing various versions again, which was officially declared by Ministry of Health and Family Welfare, and we know how the addendum and things have changed over a period of time, which we all are versed with, and we are going to discuss certain pertinent issues. So we will have a case scenario. This is a 32-year-old male. I would put it subject H. H is, I will come to that. He has having history of low-grade fever for 3 days, along with body ache, headache, and myalgia. No comorbidities. And now people are smart, they know what all things to kept at home. So he has thermometer at home, he had a pulse oximeter at home, and he calls up his family doctor that my pulse is 100 per minute, I have a temperature of 99.5 degree, and SpO2 is well maintained 98 degree. So he was instructed to go for certain test. So this our subject H goes the routine test. He was advised the CBC were total count of 5,400, differential fairly okay, platelets were normal, SGPT marginally raised 42, CRP was bang normal, and the doctor had asked him, so he got COVID-19 RT-PCR, which was positive. His X-ray chest was normal, so obviously he was given an option and it was allowed, so he opted for that I would like to go for a home quarantine. So his doctor said, okay, we will be in touch with it and you can go for home quarantine. Now, we go to the same family. The H was the husband, and now his father, who is a 62-year-old male, who is also residing in the same house. So his subject F. F is father. He is also having history of low-grade fever for 2 days, along with body ache. He had a history of difficulty in breathing since 1 day. He has a history of PTCA, angioplasty done 2 years back. And again, his parameters, when we said he had a mild tachycardia, he was a little more febrile, and SpO2 was 85%, which was reported. And this was his report. The father, whose WBC count little lower side, 4,400. Differential was polymorph 76, lympho 20, eosinophil 3 mono 1. Platelets was little bit lower side, SGPT slightly elevated, CRP was elevated, COVID-19 RT-PCR was positive. He was advised also HRCT chest, Corad 6 was labeled, and he was immediately asked to get hospitalized. He had a bilateral basal consolidation, so admitted to hospital, and within a day he worsened and shifted to ICU. So this was the father. Now at the same time, the mother of the patient who was there, she is a 60-year-old female. She also had a low-grade fever for one day along with just body ache. She is diabetic since 8 years. Pulse 100, temperature also 100, saturation slightly lower side 92. Her sugars were 375. Hers also COVID-19 RT-PCR was positive, and the doctor said, you are diabetic, you are 60, better get hospitalized. Though your parameters are otherwise okay with a little low SpO2, you better get hospitalized. So she also got hospitalized. So this is subject and mother. And obviously the original patient's wife also worried. She is a 29-year-old female, subject W, wife. She is absolutely asymptomatic, but on insisting, she got herself tested, COVID-19 RT-PCR positive. Baseline investigations were done, which were within normal limits. So friends, just to give you a case summary, we have a subject F who is the father who had to be hospitalized in ICU. M, subject M, mother who was hospitalized. She went to the ward. She was diabetic. Father was post-PTCA case. Husband, subject at home quarantine. Of course, he was mild symptoms. And wife who is asymptomatic positive. So this is the case scenario. I'm sure all of you must be seeing day in and day out. We are seeing such cases where multiple family members are getting involved in one house in Bombay so often. So let's come to, I would start with Dr. Bamin Tada. Sir, what therapy will you offer to subject W, wife, who has been found as who is asymptomatic and has been found as COVID-19 RT-PCR positive? And in extension, I will ask, is there a role of vitamin C, vitamin D, and the zinc, and at what dosage? Dr. Tada, please.
Dr. Tada, please unmute.
Yeah, I think basically I must admit that I have I come to learn from you. Actively involved in the clinics, and for the last nearly 10 years I'm medical technocrat, bureaucrat, and right now I'm working as a medical secretary. So rule could be, I think you have to really improve the immune system. So I think that is one of the main reasons. And then, of course, vitamin C, zinc, and vitamin D, we have to really supplement. This is, I think, with all the, precautions, we have to, this could be ideal for the home quarantine. But then home quarantine also, you're really required to be a well ventilated room, separate room, so that, we can really prevent. I personally feel that I think we have to really observe this and give proper diet and all the supplements of vitamins until it's really required to be. So, and if necessary, I think we can give a protospectral antibiotics also we can give.
Okay, so here, the standard first thing is we routinely recommend that they should have an SMS. SMS, social distancing, S for social distancing, M for mask, and S for sanitization, which should be the standard protocol. So all those, obviously the SMS, which is being followed over there. And as you, sir, said rightly, because whatever the best thing patient being asymptomatic, maybe a nutraceuticals which can be given, which is vitamin C, vitamin D, and zinc. So, Agam, would you like to suggest any particular dosage which you would recommend for giving these vitamins?
Yeah, there's a lot of confusion regarding dosages of zinc. I really do not know what kind of dose would be enough, but then there are preparations which are available having 15 milligrams. There are preparations which are available having somewhere around 50 milligrams. I think I would be happy so far as patients are taking, one vitamin C, one zinc, and probably vitamin D supplementation. Now, whether to treat everybody with vitamin D supplementation or to get their vitamin D levels, and if their vitamin D levels are low, then only to probably give corrective doses or maintenance doses are all debatable things. But during pandemic times, I think I wouldn't waste much of time on doing all that. I would put them on all these possible supplements. They have some role for sure, and I am very certain in my mind that they do no harm. That is for sure. So I think I would continue this treatment.
Fine. So here the recommendation, at least even an asymptomatic individual can receive safely vitamin C, vitamin D, and zinc. And obviously, this is the time we don't ask for checking for vitamin D levels and C, because it has been found that more than 90% of our Indian population are anyway vitamin D deficient. So you can overall safely be giving, unless somebody who is on a very high dose vitamin taking on a daily basis. That is the thing which we can do. So this is what I think, besides which probably anybody has a different view, asymptomatic, positive patient, anything want to offer. Any Dr. Talwar or Dr. Guleria, sir, do you have any different viewpoint than this?
I would tend to agree. There are some data which is emerging that vitamin D at higher dose can also be given. There are some groups which give vitamin D almost 60,000 units every alternate day for the first few days, and they're trying to show that actually helps as far as immunity is concerned in decreasing the viral load. So some give a much higher dose of vitamin D than what we traditionally give in patients who have a low vitamin D levels. Vitamin C also is given. Usually people would give 500 milligram twice a day. And as far as zinc is also concerned, as was already mentioned by Agam, there's no clear-cut guidelines. Normally any multivitamin which has some degree of zinc preparation can also be given. Again, these are the data for the utility of all of these nutraceuticals is to some extent not that strong. But as you said, they probably do no harm and may provide some benefit, if at all, so they could actually be given in mild or asymptomatic individuals.
Right. Thank you, sir. So that is
Ketan, only one word I'll say is that, this concoction is the one which is going around for pretty long now, and leave beside all grades and all shades of COVID-19, even those among the healthcare workers and all those knowledgeable people, everybody is taking this concoction anyways. I do not know how much evidence is there in healthy people, but then this is something which has become almost a rage among healthy people who are even going outside their house. They are all taking this concoction for daily purpose.
Yes, absolutely. I
do not know the evidence.
So here I am taking practically. How many of you are? Dr. Dhar is taking. Agam is also taking. I presume chewable tablet.
No, sir, I'm not taking. So just one word to add, Ketan. So I think if we are giving this, so we are recommending this for a 30-year-old healthy person.
Yeah.
So basically, if we are recommending for this individual, we are actually recommending for every patient with COVID.
Yeah.
So there has to be some degree of rationale. There's a CTRI trial which is on just now, which looks at a combination of hydroxychloroquine along with this concoction of vitamin C, vitamin D, and zinc. And I know of 3 other trials which are happening throughout the world. So I agree with everyone. I think it is a possibility that you give this, but I probably wouldn't say a blanket yes for every patient with COVID who comes should get this concoction.
Right.
No, I think one more thing. See, these are asymptomatic patients, and there is something called as placebo therapy. You have to offer them something. When they come to you with RT-PCR positive report, there is so much of shock on their face. Huh? Kuch nahi diya? No treatment. And then Ketan can't charge those 1,500 rupees unless you prescribe them something. So then in that situation, probably there is no harm in putting them on some simple combinations where there is some role of vitamin C, some role of vitamin D, some role of zinc. I think I would be tempted to put them on therapy, irrespective of their age, irrespective of their otherwise immune status.
Okay, so fine. Now let's move on to further. So that is what we see. Now, as sir has already mentioned about HCQS, so again, I will come back to Guleria, sir. Again, this is Pandora's box. We know, sir would say agree with it. And you say, sir, where will you use HCQS? Now you have got 4 subjects, husband, wife, mother and father. So out of these 4, and where you will use, wife is asymptomatic, husband is mild symptomatic at home, mother is diabetic in home, hospitalized, and father is bad in the hospital in ICU. So
I think you must give one more option to Guleria, sir. Give one more option that his treating doctor.
Yeah.
The family's treating doctor, whether he should take it, give 5 options.
Correct. So Guleria, sir, your viewpoint, sir, about HCQS.
I think HCQS is one drug which is surrounded by a lot of controversies. It's literally become political. It's almost as if you have to decide whether you're pro-Trump or anti-Trump when it comes to using HCQS. So it's, but whatever data is available, it's not conclusive. I would say that the data currently is moving towards against the use of HCQS. The Indian guidelines, however, still recommended, and they would say that in mild cases, HCQS can be used. And as was mentioned, in healthcare workers who are coming in close contact with COVID-19 patients, it may be useful. The data for healthcare workers has actually come mainly from India. And this is based on 3 studies, one which was done as a study from our own center, which looked at hydroxychloroquine among healthcare workers in the COVID hospital. There's another study which was done from Delhi hospitals, and one other study which ICMR has published in IJMR, which they looked at multiple sites. It was a questionnaire-based study, and they tried to look at the efficacy of hydroxychloroquine healthcare workers as compared to those who did not take it. The ICMR study actually even showed that there was a dose-response relationship, that those individuals who took the loading dose of hydroxychloroquine and subsequently the weekly dose, there was a tendency to have less COVID-19 infection as compared to those who did not take, and then it was better in those who took the first loading dose, and the incidence of infection was much higher in those who did not take hydroxychloroquine. However, you can debate on this because it may also be that those who were taking the drug regularly also had a very appropriate behavior in terms of protection, in terms of wearing PPEs, in terms of wearing their N95 mask, and therefore that needs to be teased out from the data. But the 3 studies did tend to point that hydroxychloroquine does or may have a prophylactic role, and that's why the guidelines continue to recommend it. The data for mild cases is only from the initial studies which had come for the utility of hydroxychloroquine, and these were studies which are not that well powered. Subsequently, trials have not really shown hydroxychloroquine to be very useful, so it's a debatable issue. But if you have to use it, we would use it in individuals who have mild illness as far as its utility is concerned. So I think the wife had a mild illness. I'm still trying to figure out who had a
wife is asymptomatic.
Wife is asymptomatic. So
yes,
then each had mild illness.
So husband has symptoms. So you can recommend, you think that can be useful. And for mother and father who are hospitalized, both of them, you would not like to use it.
Right.
Right, sir. Now, even the ICMR is still, as of now, with lot of controversies, still even the last recommendation which has come out still also mentions HCQS continue to use for a mild to moderate cases, what that is. So, of course, the debatable issue, and after there was an article which came in the Lancet and NEGM which created lot of controversies and about the authenticity of the publications which all of us are well aware about, that created so much chaos across the globe. Everybody started looking about the authenticity of the publications and all, but the fight is still on, and as you said, it is, as of now, we can just only recommend for mild cases where it can be recommended.
Ketan, can I ask Dr. Guleria a question?
Yeah.
So I think you said in your presentation that the husband is actually isolating at home. Is that correct?
Correct.
So Randeep, would you actually give the drug in a patient who is actually on home isolation in a treatment dose?
So we would give 400 milligram twice a day with meals on day 1, followed by 400 milligram once a day. You could give it in split dose also with meals for the next 4 days.
And you would give it on a domiciliary basis, is my question.
Yes. So I think from the safety point of view, I think there has been a lot of issues about hydroxychloroquine from the safety point of view. Most of us, at least I have been using hydroxychloroquine for more than 20 years for sarcoidosis and for a large number of diseases like SLE. And I've been giving a much higher dose on a regular basis. I have patients who are on hydroxychloroquine for more than 7 to 8 years. And I've never really done anything. In the beginning when we did a randomized trial on looking at HCQS in mild patients with sarcoid, we used to do an eye examination to look for the retinal involvement. But I even reviewed the literature at that point in time, and this actually emerged from the use of chloroquine. There is data in this from the 60s and 70s where chloroquine was used for treatment of sarcoid, and what they found was that when it was given for a few months, it causes very high chances of retinitis. Because of that, when we first started using it, we used to do eye examination every 3 months. But even if you look at the recommendation of the Royal College of Ophthalmology, they have said that it is very safe even from the eye point of view, and there is no need to do a regular checkup, and we don't do that. So I think I'm quite comfortable as far as the safety of hydroxychloroquine is concerned. My concern is only, do we have enough evidence as far as its efficacy is concerned?
Right.
And I want one comment. Yeah. So Randeep, this family was very lucky. Actually, everybody got positive. There are general families where a lot of members are still not positive. So like in healthcare workers, it is recommended to give them prophylaxis of hydroxychloroquine. Would you recommend in them, like, this is what is there in the ICMR guideline also, the family members who are negative, COVID negative, for a prophylaxis which is varying from 4 weeks to 6 weeks. So what's your take on that?
So the guidelines also recommend that close contacts of those patients who are RT-PCR positive for COVID-19 should also be given hydroxychloroquine. Here, because of the lot of concern that was raised, which I think, like I said, may not be that founded, we do recommend that in high risk group, you could get an ECG done or you could evaluate from that point of view. But yes, that is also recommended. But again, like I said, the more recent data for prophylaxis of HCQS is not strong. However, we need to look at this data very closely because this has now taken sort of political overtones and I would say industry overtones. You know, it's a competition between a drug which is very cheap and a drug which may be very expensive. And sometimes there is a bias which may creep in because we have a very strong lobby as far as industry is concerned.
Right.
If I may add, Ketan, I remember pushing at least 10 or 15 of my colleagues in taking hydroxychloroquine on regular basis. I myself take it every week. I give it to Bijal and my mummy, papa both take it, you know. I used to see about 30 indoor patients daily and about 10 or 15 OPD patients with suspected, kind of in this pandemic, you would any flu-like symptoms coming would be COVID suspect. I used to see that kind of patients. With all due respect to whatever PP kits, etc., you don't have that kind of protection in OPDs. You know, when you take ICU rounds, you are fully protected. But in wards and in OPDs, you can't take that much. And wearing those PP kits in OPD, I've never done that. A lot of my doctor colleagues who are taking HCQs, none of them have got it. 2 of my doctor friends got it. One is Dr. Mangesh Tivaskar who got it. Had relatively milder course. So I think I'm in favor for hydroxychloroquine. I would say that yes, what Sir said, ECG and probably retinal evaluation, if there are no contraindication, I would safely give them hydroxychloroquine. Yeah. Now there is some more data which talks about Ivermectin also. Ketan may have some slides on it.
We'll be coming back.
Probably yes.
So here the issue about the QT prolongation on ECG, which was really hyped up. In fact, per se, hydroxychloroquine itself does not cause QT prolongation if given as a single drug without a patient who are not on any other drugs which are causing QT prolongation. So that is one thing. Even when it is been taken as a prophylaxis, you don't require any ECG also for that matter if they are not on any other drug causing QT prolongation. So probably that issue was really hyped up by lot of, whether it was a pharma gimmick or whatever has been said, it had become a really political, more of a political war. But at least we got the message over here. Let's move on to the separate subject. Otherwise, our full panel discussion can go only on HCQS only. Okay. So coming to Dr. Talwar, sir, please. Now, azithromycin, which came as a big way, and over a period of time, doxycycline took a preference. So, sir, your preference of using azithromycin or doxycycline, and now obviously which we have decided, the wife who is asymptomatic, we are not going to give her touch anything, but husband, mother and father, will you be giving to all three, and which will be your preference? And
so Ketan, it depends whether which part of the month I saw this patient. So if I had seen this patient in April and May, I would have standard given azithromycin and hydroxychloroquine.
No, August, 15th August.
Now, July onwards, I got started scaring about the combination of azithromycin and hydroxychloroquine. So I started with hydroxychloroquine and doxycycline or ivermectin, one of them. So right now, we are using back to hydroxychloroquine and azithromycin, or if there is a contraindication to use them, then only to go for doxy or ivermectin. That's what we are using at present. We have a data, as I think Randeep will also allude to it, that it's not favoring anything very specific. The only thing which came out was that you can't combine azithromycin with hydroxychloroquine. They will increase the QTC more. They'll cause more toxicities, but which is also ill-founded.
Right. And will you give it to...
I will give it to the young man. I will give it to the young man who's quarantining at home.
Yes. And for mother, father, will you be using, or the next question is, when will you prefer parenteral antibacterial? The mother, father, both are hospitalized, where you would use parenteral drug?
Yeah, so Ketan, using antibiotics in hospitalized patients, obviously if they are in the hospital, whether they are in the ward or the ICU, they will be getting a minimum IV antibiotic, which will be like either I'll be using azithromycin again or even augmentin. But in the ICU setting, obviously the choice of antibiotic will be more broad spectrum at that point of time.
Correct. So the father who is admitted in ICU with a lung involvement, bilateral basal consolidation, you would prefer definitely to use a parenteral antibiotic here, which would be broader spectrum. Fine. That's okay. Now we move on to another aspect, which again Agam is waiting since long. So I will not ask specifically to Agam now, because this is where Agam was too keen. I would ask Dr. Rajadhar, role of ivermectin, the dosage, when it came, again, there was a different dosage and duration. And for our three subjects, because now we are not taking into consideration wife, because who is just asymptomatic. So will you give to husband, mother, father, all three, or whom? So Dr. Rajadhar, please.
So I think this is a drug which has been, again, sort of like HCQS, a drug which is cheap. It's widely available, and we've got a lot of experience using the drug as an antiparasitic. I think the FDA approved this drug a little while ago for the use in COVID-19, and it has sound theoretical background. So it causes significant reduction in virus in 48 hours on a cell culture. So there's sound ground. Unfortunately, like the other drugs, I think the data is still not available. I think the single trial or the couple of trials, one from Bangladesh and one from Chile, have not really given a very robust evidence as far as clinical cure rates are concerned. There is reduction of viral replication. So in the very mild patient, I would probably use ivermectin. I would go along with the regime of 12 milligram on three successive days. I think that's probably got whatever data we've got. That's probably the dose at which we have the best data. Where would I use it? I think at the moment, and I know you will come back to this later on, Ketan, but as of now, in my very mild patients, I would probably use favipiravir as first line. And if for some reason, whatever that is, I am not able to use favipiravir, Ivermectin would be my next choice as far as use of second line is concerned. So if I had to use the drug, I would use it in the husband. I would definitely not use it in the mother or the father who are hospitalized.
Okay, so very crisp answer. So we got the message. So after a lot of confusion about the dosage and duration, very nicely you said about the 12 milligram once a day for 3 consecutive days. Will it make a sense that somebody who is presenting on day 3 of presentation and sometimes somebody who comes on day 6 or somebody who comes on day 10? So does it have any impact on starting at the timing of from the timing of symptoms? Dr. Rajadhar?
So I think across the board, Ketan, it's probably better to start early. So with the antivirals, with Ivermectin, with HCQS, and even for drugs that you're going to discuss, which are in the severe category, the carry-home message is use early in individual categories where it is licensed. If you use it late, the efficacy of the drug and for mild disease to go into severe disease is going to be greater. So the carry-home message is use early. Using on day 3 is better than using on day 6. Day 6 is better than using on day 10, for instance. So earlier, better is the carry-home message. Correct.
So that's a good message. We'll come to the other segment. So, Dr. Bamin Tada, sir, what are the indications of steroids in COVID-19? So, and like for our subjects, for whom will you recommend to use? Will it be for the father, mother, or the son or husband who is there? So steroids for whom? So what will be the indications of using steroids and for whom you will use it? So first 2 questions, sir. Dr. Bamin Tada, please.
I think role of steroid applicable for the father and then because and especially I think it is essential. Choice of the dexamethasone, I think we can go up to 1 week to 10 days, and if they can prolong
weak, sir. I think your signals are weak, probably. Okay.
Line is.
Your signals are weak, sir.
Yeah, there is a definite indication of. There is definite indication of steroids, especially dexamethasone. I think applicable for father and mother as they are hospitalized. Also, I think they are on the ventilation required.
Okay.
And duration, I think we can 1 week to 15 days we can go for. And dexamethasone is a dosage. I think it is dosage. I'm not very sure what dosage you have to give. I think all of you who are in clinics, you must be knowing.
Agam, so your what will be your choice of steroids and then the dosage?
So here I have 2 things to do. One is what I talk and what I practice. Okay. Yeah. So first, what I talk. What I talk is that steroids should not be given in the initial phase of viremic phase. We know that there is initial asymptomatic phase where the replication is most, then comes the viremic phase, and then comes in some patient a cytokine storm and probably complication related to that or a recovery phase. There is a trick of using steroid. So if you use steroid too early and in too high dose, probably it may enhance the viral replication and probably there may be more of viremia. And frankly speaking, steroid may not have role in the early part of disease, but yes, for sure, when there is a organizing pneumonia pattern or where there is fibrosis setting in, when there is lung destruction going on or where there is cytokine storm setting in, probably that is the time one would use steroid. Literature again, as Dr. Tada sir very rightly said, goes more in favor of dexamethasone and one should use that. About me, I have never used dexamethasone. I have never liked dexamethasone. As chest physician, most of us always liked a shorter acting steroids, and probably there is a preference over methylprednisolone. And so then general trend is to use methylprednisolone. I use about 40 milligrams of methylprednisolone to begin with if there is moderate radiological involvement and if there is hypoxia. I would use it to begin with. If patient does not have much of pulmonary involvement, if patient is non-hospitalized patient, probably in those situations you don't need steroids. I would continue steroids if the cytokine storm probably is there. I would continue it all throughout. Or if patient is probably responding, I would continue it for about 10 days to 2 weeks, depending on, again, various parameters. So there is no clear cutoff. It's not like antibiotics where you would stop it at 7 days, 10 days, 14 days. It goes more on a clinical evaluation, but I would safely continue it for about 2 weeks. So that's what I practice.
Right. So here in this subject where mother and father both you would like to give steroids, right? The both
Yes.
are, okay. And
Yes.
for
So can I, sorry, I'll probably differ there a little bit with Agam. So I completely agree with his rationale. I love the theoretical part with dexamethasone and the bit with methylpred. So my practice would be that if a patient needs oxygen to maintain saturations above 90%, that would be the segment of patients where I would give a steroid. I agree with Agam that the poison of choice would be methylpred. I would actually use a slightly higher dose than what he mentioned. I would probably give 40 milligram twice a day, rather than 40 milligram once a day. I wouldn't use it in a patient who's not needing oxygen. Again, going by the very theory that he spoke about. So it's viral replication versus correction of ARDS. That's what you try and weigh. If it's viral replication you're worried about early on, you do not give the steroid, which is why you don't give it in patients not requiring oxygen. And the patients who are requiring oxygen, you think more about the ARDS and worry less about the viral replication. And hence you would give it to the cohort of patients who would require oxygen. So in my book, it's the man who is in intensive care who's requiring oxygen who would be the person for steroids.
I would tend to agree with that.
Guleria.
Is that we would give steroids basically in those whose saturation is falling, who's requiring steroids, and are going into a chest X-ray which is actually showing worsening. So in those patients who have now features of moderate disease, maybe advancing towards more severe disease, we would give steroids. We also would prefer methylprednisolone 0.5 to 1 milligram per kg. Some of our group also uses dexamethasone varying from 4 to 6 milligram. The duration is something controversial. Some people give it for 5 days, others have given it for 10 days. And then depending upon if you feel that there is some degree of chances of a post-COVID syndrome, that is post-ARDS effect with pulmonary fibrosis happening, you may continue steroids even for a much longer time, hoping that it may help in decreasing the fibrotic lung disease, which is also a big problem that is coming up as far as COVID-19 is concerned.
Okay. So whether we give this message to our delegates that even with a mild lung involvement, because nowadays the trend is, HRCT is being done for each and everyone who has been found to be positive and gets hospitalized. So even if they have got mild to moderate cases, but not requiring oxygen or not worsening, we don't give steroids. Is that the message, sir? Can we pass it on to the delegates?
I think that is very important. It's also important to remember that studies now show that almost 20 to 30% of asymptomatic individuals, if you do a CT in them, you may find some lung patches which will resolve on their own. So don't go by the lung involvement on CT scan to decide on the treatment for steroids. Look at your saturation and how the patient is behaving, because that is very important. You may start steroids too early and this may actually lead to more viral replication and more deterioration of the patient. So I think it's important to be careful about how you judge your patients, and I won't advise that just looking at a patch on the X-ray is not an indication to start steroids.
Yeah, and one more issue.
Ketan, can I ask Dr. Randeep one question?
Yes,
Randeep,
sure.
like falling saturation, what is that falling saturation which we advise these people? Basically, there are a lot of doctors themselves who will be very happy to start the steroids. But it's basically for them, the question is that how much fall in saturation is the trigger point for them? Because the CT scan is showing ground glass opacities anyways to them.
So you would like to actually look at the saturation which is going below 93. And if it's actually below 90, 88 to 90, I think then you're really going to look at giving this patient high flow oxygen, conscious proning, and a more aggressive management. So if your saturation starts falling to below 93 or less, you would actually start getting worried and start considering giving steroids.
So I think that ICMR guideline of 94 is good enough, that less than 94 it goes. Normally you have 98, you have more than 4% fall in saturation. And if you have CT findings to show there are ground glass opacities, that will make a case for starting the steroids. I think this is more relevant to physicians themselves because they are more happy to start as soon as possible rather than delaying it and waiting even if the oxygenation parameter is fulfilled or not to start the steroids.
Yeah, you said rightly, because what happens, people get tempted just getting a routine CT, HRCT chest done, and maybe a small segmental area which is involved, and then they get tempted to start steroids. But a very nice message given by you. And another point which happens is, the diabetics, whenever they are given methylprednisolone, the sugar just goes haywire. So it is one more things which comes in the way of managing on that. So probably the very nice.
Let me add something. Ketan, I don't think methylprednisolone should be blamed for this. When you give equipotent dosages, all steroids would give you the same effect. You are giving 4 milligrams of methylprednisolone, and if you give 6 milligrams of deflazacort, your sugar fluctuations are going to be the same. It's only that you very happily give 16 milligrams of methylprednisolone, but you never give 30 milligrams of deflazacort. Do you ever remember giving 3 tablets of deflazacort 30 milligrams to a patient during acute exacerbation? You would have never done that, but you safely give 40 milligrams 3 times a day of methylprednisolones, and then, the sugars fluctuate. So then trust me, all steroid would bring about fluctuations in sugar. It's not that only methylprednisolone should be blamed.
No,
so
only
that's the message I wanted to give.
Yeah,
and second thing I wanted to tell you about your radiology, you did mention in your slide about CORAD. So CORAD is one thing which talks about probability of it being, COVID, but at the same time, there is scoring system available. So one has to look at scoring also. When you have a moderate scoring on CT scan in any symptomatic patient, this patient must be very closely watched for. That means most of this patient would deteriorate. Most of this patient will have probably hypoxia, and especially if they have underlying other metabolic disorders. So I would consider putting them on close observation and would consider steroids in them. That is what I was talking.
Fine. Thank you, Agam. We'll move on to further. Next is now I would ask Dr. Talwar sir, what is your experience? Initially, the recommendation came about the use of antiviral therapies which were used for hepatitis. And first of all, which came was lopinavir-ritonavir combination. And of late, the papers have come, the newer therapies which is used for hepatitis C, that is sofosbuvir plus declatasvir, which has also been found to have a beneficial. So you have any experience, Dr. Talwar sir, with this?
So quickly answering this, Ketan, as far as declasofo is concerned, only my friend Dr. Dhruv Chaudhary from Rohtak keeps telling me it is very, very effective. I do not know about it because I have not used it so far. Lopina Ritono we have been using prior to we had availability whenever we had the issues of availability of remdesivir or we didn't have a favipiravir. At that point we were using this combination. That was in April and May. But now, by and large, we have shifted this antiviral spectrum to more of favipiravir and remdesivir. So I have not much experience at the moment of Sofo plus Decla.
Right. So only thing is the gastroenterologists are now, seeing that so often in a routine detection, somebody who is found to be Hep C positive and also COVID positive, we have started seeing co-conditions together. And if they have to start, then they are very happy starting Decla with Sofo, which works both excellent in Hep C as well as for the COVID, which the rapers. But of course, the experience is limited. So I presume
Ketan, the data is primarily like there are centers who are doing hepatitis C on with the patients who are on Sofo Declo. They found that their patient never had this thing COVID-19. So they are getting basically a retrospective review from that. But similarly, I think we also have, just Randeep said that so many patients on hydroxychloroquine, they also haven't got COVID-19 so far. So I think this is all collaborative data, which is primarily because of the retrospective vision which we are trying to get into it. But I don't think so clear data is right now available.
Okay. And just a quick question. Anybody from the panel using in today's time lopinavir plus ritonavir combination? Anybody from the
I don't think we can actually support it, Ketan. I mean, given today's day, when you've got an antiviral for mild disease and one for severe disease, which are approved of trials, and combination which has actually not been seen to do anything on the recovery trial, I don't think we can actually justify using loperitol just now.
Perfect. So we'll move on
and
further.
actually speaking, favipiravir is far easy to pronounce than the sulfonamide and whatever you said. I think I would go for the easily pronounceable drugs than those difficult.
It took me, I will write the spell also correctly. It took me, I checked it twice that I am writing the correct spelling also.
No, I was jealous. You pronounce it in minute without a delay. I was just watching you how you're pronouncing this name, but you did wonderful job.
Okay. So as you mentioned, now we are coming to favipiravir. When it started, how the things have changed. So of course I will come to since Agam mentioned about now which subject will you use? Wife, of course you are not going to touch wife. So about the husband, mother, and father. So out of these three,
right. Vijal is here and she doesn't like me touching anybody's wife. So then that question is out. What you said, I won't touch her wife. Okay. Regarding favipiravir, I think favipiravir I would consider for mild to moderate cases. In the sense, I would not mind considering. I think मैं भूल जाता हूँ what you said. The mother is in ICU, right? So the mother who's in ICU.
Mother is in ward. Mother is diabetic and she is in the wards. Father having post PTCA and bad lung. So father is in
ICU.
Yeah.
Father is in ICU. So I would not probably consider favipiravir there. I would ask. I would use remdesivir there. For both other situations, I would consider favipiravir. I think favipiravir is the drug which is considered for mild to moderate cases of COVID, and both these cases fit well into it.
So even the husband, the gentleman who is at home quarantine, who is having mild symptoms, you would recommend favipiravir, right?
So you have a choice there. You could offer him doxy-ivermectin combination, you could offer him HCQ azithromycin combination, and you could offer him favipiravir. All this, the mild patients probably could receive any of this therapy.
Now, will your decision about the duration, because duration again, so will it be different for the gentleman who is at home and for the mother? Duration, yes.
Now the duration, what literature mention is about 14 days, but then you have to, you have to decide depending on patient's response to treatment. See, if the patient who's in wards, you put them on treatment and patient deteriorates over time, I would safely stop that favipiravir and put this patient on remdesivir and shift this patient to ICU. In the patient who's at home quarantine, probably develops any symptom, he would definitely be advised hospitalization and probably treatment will be accordingly modified. If patient continues to improve, see patient who's on home quarantine, if his symptoms disappear, if his cough goes away, fever goes away, breathlessness is not there, probably I would stop this therapy on 5th or 7th day. If patient who's in hospital continue to be symptomatic and has radiological involvement, probably I would continue it for full 14 days duration. There is no sense in giving this drug beyond 14 days. I think I would stop at 14 days.
So 7 to 14 days is the thing which you are looking at it. And in your personal experience, what are the common side effects you have observed or come across while using favipiravir?
Excellent. Ketan, that's an excellent point. When I started using it, I have about 120 plus patients who are on favipiravir now or who have completed favipiravir therapy. I have found it extremely safe. There is a loading dose required. On day one, you need to give them 9 tablets in the morning, 9 tablets in the evening. If you're using 200 milligram tablet, that is 1800 morning and 1800 evening. That is what you give. And that loading dose gives you probably loose motion. So I feel a lot of patients develop loose motion on day 2, day 3. And it is a self-limiting loose motion. Now, I don't know whether these loose motions are due to drug or they are part of disease itself. Because a lot of my gastro colleagues feel that I put them on treatment very early. Because as Raja said, probably you should initiate it as early as possible. So I like to introduce drug in 24 to 48 hours. A lot of my gastro colleagues tell me that this may be presentation of COVID GI involvement. So I don't know whether it is COVID GI involvement which gets better with favipiravir on day 2, day 3, or it is the loading dose of favipiravir which gives you loose motion which settles on day 2, day 3. I have not stopped favipiravir for the want of side effects. That means in none of these patients I had to stop favipiravir. All you do is give them fluid replacement. Probably, ask them to match the intake accordingly. And give them some salt supplements, etc. But you don't require any anti-motility, you don't require any, all those low motels and etc. Treatment is not required for them. I have seen probably transient rise in OTPT. And that too because in indoor patients, you tend to over-investigate. Every day 2, day 3, you started doing tests. Otherwise, there was no clinical indication for asking for this test. And probably in next 1.5 to 2 months, we got wiser and we stopped asking for it. So I don't see much of problem there. In most of these patients, probably rises 2 to 3 times. That is somewhere around 150. OTPT becomes. They don't rise beyond that. Again, I have not stopped favipiravir for side effect in any of these patients, liver related also. And third, probably in the webinars I learned that probably this drug gives rise to uric acid elevation also, because I never asked for uric acid in any of my patients. None of my patients complained of specific joint pain. They had joint pain which was thought always due to viral disease, and probably it settled on its own. In the previous meeting, Raja told me that probably a lot of patients do get uric acid elevations, and so I started looking at it, but then probably I have not really modified treatment based on that as well. So there are 3 mentioned side effects. One is loose motion, second is alteration of liver enzyme, and third is elevation of uric acid. Otherwise, there are no major side effects.
Right. But
can I ask a question, Ketan?
Yeah.
Can I ask Dr. Guleria a question? So completely agreed with what Agam has said about favipiravir.
Right.
So Dr. Guleria, bench to bedside. So your reading of the literature and then translating into clinical practice, Agam mentioned 3 choices. So HCQS plus minus azithromycin, Ivermectin, doxycycline, and now favipiravir. How would you grade these? Which patients? How do you select, if at all?
This is a very difficult question because at the end of the day, it's an individual choice as to what you want to use. There is no real hard data to support it. If you look at data which is available, there's on a relative basis probably some data which is a little bit more as far as ivermectin and hydroxychloroquine is concerned as compared to favipiravir. Favipiravir, we all know, was a drug which was basically for influenza and was introduced in 2014 for H1N1, and subsequently has been shown to have a wide antiviral activity. There's a randomized control trial of it being used also for Ebola with actually a positive result. But the data for COVID-19 is not that strong. The one paper which is quoted a lot is the one which is actually published in a non-medical journal. It's a journal called Engineering. And therefore, there is a lot of debate even in the joint monitoring group, which is chaired by the Director General Health Services, as to how to position this drug, because it is now available in India based on the evidence. And although the evidence for all these 3 drugs is not strong, it is actually an individual choice on how comfortable you are in using any of those. I think we don't have enough evidence to say one is better than the other as of now, and we will probably need more head-to-head comparison before we can really say that upfront.
Okay.
So, Ketan, can I make a comment?
Yes, sir. Yes, sir.
I agree to what everybody has said about favipiravir. The data only suggests that the fever differs early, the cough is little better early, breathlessness, God knows how much helpful it is in that. And the only thing which is different from what Agam has said, that in mildly patients who are home quarantine, stopping them as soon as they become afebrile or they feel better, because some amount of cough will persist for a little longer period of time. So stopping at day 5 or day 7 of favipiravir is generally what we do not do, and would like to carry on at least minimum of 10 days. We have no data. Data is up to 14 days only. That's the one thing which I wanted to make comment. And second, I think what Randeep has made very clear, the data is much more stronger for remdesivir, especially for the father who's admitted with 92% saturation. Sorry, the mother who's diabetic with 92% saturation in the ward. She is also a candidate for early remdesivir rather than favipiravir at this point of time, because the saturation has already gone down in that patient, and probably this patient requires a quick addressal of the issue that the patient might deteriorate into severe, where the patient might have to be shifted into the ICU very soon. So I would differ on that, but rest, of course, home quarantine and mildly symptomatic patients, I personally feel it is an antiviral. And when you are talking about antiviral, it's a viral disease. Obviously, it makes more sense to use it early, and perhaps in mild cases as soon as you diagnose it. But that leads me one question to Dr. Randeep, that in such patients, when we have asked for a COVID test already and the report takes about 2 days, and you have a high clinical suspicion of it being COVID, and patients are mild, and at that point of time, is there any way that you would consider starting favipiravir, because we know it prevents progression from mild to moderate disease in some cases? At least that data is there. Need for oxygenation or oxygenation worsening is reduced. So at least we have this data to suggest, but that means we should start as soon as possible. if this is taking 2 days for RT-PCR report to come, so is it not worthwhile to start it at that point of time, which we are not able to do because it is under the informed consent process where everything has to be started the moment you have a COVID positive report only? Randeep.
So this is a question which I get every day. We hold this EICUs, and even it's more complicated than what you said. You made it sound very simple, but it's suppose you have a person who's deteriorated and who needs remdesivir. Saturation, the mother you said, saturation was falling and who is now critically ill. You have an X-ray which shows the classical peripheral ground glass appearance, and the patient has classical features of COVID, but the RT-PCR has come as negative. Would you take the risk and give this patient remdesivir even if the RT-PCR is negative, or would you go ahead and do more testing, maybe a lavage to make sure that now it's in the lower airways and you may pick it up? And with that waste precious time as far as the patient's condition is concerned. So I think these are issues which we will have to really address. In my mind, you have to discuss this with the patient and the family. And if you can talk to them, and if they are willing to take the risk and they give the consent, then even with a negative report, you could consider adding a treatment. But you have to be very careful. I remember just yesterday, as a matter of fact, one person who was from the Northeast telling me that he had a similar patient, and then we did a lavage and it came out to be Legionella. And the patient improved with treatment, although it looked very classically like COVID-19. So you have to really look at it on a case-to-case basis as to what the shadow looks like. Atypical pneumonia can happen because of a large number of other infections also. And the gold standard continues to be RT-PCR. We would say that you talk to the attendants and see, and the family, and at the same time aggressively try and do testing. You could use the rapid antigen kit, you could use the CBNAT, all of which would give you a result within 15 minutes or 2 hours. But this is at times a big problem, both in patients who have mild illness, but a bigger problem in those who have moderate illness and requiring to be given drugs which are having more side effects or which require more consent.
Yes.
I need to add something.
Yeah.
Ketan, I am also very critical about this particular point. In Bombay, I always discuss in our meetings that on Bombay, suppose if you have a patient on Saturday afternoon and you suspect, this COVID, you ask for test. Earliest appointment he can get is on Monday, and earliest report he can get it is on Tuesday afternoon, unless you are asking for rapid antigen test. The RT-PCR conventional would take 3.5 days if you've seen patient on Saturday, and you can't deprive them of treatment option with favipiravir. So if you have, my understanding is very clear, and this understanding is applicable only during these pandemic times. So if you have anybody presenting to you today with influenza-like presentation, you have to treat it as COVID unless proved otherwise. Like as what sir said, probably you do lavage and you come out and get an alternative diagnosis. I would safely stop my, favipiravir at that time, and I would continue a treatment for Legionella or whatever alternative diagnosis I get. But till I don't have alternative diagnosis, I must give benefit of doubt to this patient and put them on favipiravir. So if it fits into that particular category. So if mild to moderate case, pending results, empirically one should be able to start therapy, and that is what was the discussion last week. We took up a roundtable meeting kind of a thing under the leadership of Dr. Vijay Lakshmi Thanashekaran and Dr. Samaria, and of course a lot of chairs position across the country, and we were looking at whether we can develop a consensus statement on that, and we have developed kind of something. We are working on it. Probably next few days we should be able to fine tune it, where I strongly feel during pandemics, anybody who's presenting with this kind of presentation, especially in the scenario that you've given, you have a family member, you have epidemiological, evidence to suggest that this patient has probably COVID. And even if your results are negative, and if that patient is willing to take treatment, as sir said, probably would consider discussing with him. You don't have to discuss with them today, actually. They will come out with this option. Everybody has on their WhatsApp full details about favipiravir and the status, and they would really agree for taking treatment. I have not come across a situation where any of the patient denied taking favipiravir if given option.
In fact,
is there a legal issues to it?
Correct. So I think
you have to take informed consent.
Yeah. So informed consent you have to take for every patient. I know we have discussed this before, Agam, on various forums, and I agree with you, but with the provision that you inform the patient or the relative that you're giving the drug on empiric basis, for which it is not licensed. Yes. I know. I think if you do that, you're clear, and it has to be on a case-to-case basis rather than a blanket. We will use empiric favipiravir.
I agree with that. I totally agree with that, and you have to be very careful because it does have a medical legal implication unless you take the patient on board.
Right. So, and today's time, as sir has mentioned also, probably the dosage and all, you don't have to tell them. They all are well versed with through the WhatsApp that what is the dosage. They will tell you that this is what I have to take now. So probably that is not an issue. Okay, let's move on to the further next time. Now coming back to case, now our subject F, that is the father who continued to worsen in ICU. So on 5th day, his saturation was 80% on HFNC. His HRCT was repeated, which showed worsening of the lesion. Now he has got almost 2/3 of both the lungs which are involved. His parameters, D dimer has gone to 6,500, ferritin is 1350, CRP is 180, and IL-6 which was done is 350. So these are the parameters of the gentleman, elderly gentleman who is a case of, again, just to remind, a post-PTCA case. That is the only comorbidity, and these are the parameters. Now coming over here, now will you use remdesivir for this subject F? That would be, so I will come to Dr. Rajadhar. So what do you feel, whether you would use or remdesivir over here if it has not been started? And suppose by any chance somebody has put it on 2 days back on favipiravir, will you change to remdesivir?
So Ketan, you have described probably the worst patient. This is your less than 5% population with COVID who will have a very high risk of mortality. So I guess if you've not started remdesivir as yet, you've probably missed the boat in this patient by now. So you would definitely start if you've not started. If your patient was on favipiravir, you would definitely stop the favipiravir and start remdesivir instead. But one would hope, in lines with what Dr. Talwar said, that you would have started this drug by now. So loading dose of 200 milligram once a day, followed by 100 milligram once daily, and you use the drug for between 5 to 10 days. The small trial, which wasn't very robust, showed that there wasn't very much of difference between using it for 5 days versus using it for 10 days. But in my clinical experience of using remdesivir in the severe group of patients, I think there is a difference. I think it's anecdotal, what I'm telling you. But there's a lot of patients where I would use it beyond 5 days. And similar to what we discussed about favipiravir, I think it has to be somewhere between 5 to 10 days, depending upon the response that you've elicited from the patient.
And any specific side effects you have come across?
So I guess these patients are quite unwell, Ketan. So there are side effects. So you would think about transaminitis. You would worry about the patients who've got a creatinine clearance of less than 30, or in patients who've got on hemodialysis. Till very recently, we would use it on patients on hemodialysis in Kolkata, like they're using globally. The problem was that the remdesivir trial actually excluded patients with a creatinine clearance of less than 30 and on hemodialysis from the trials. We don't really know what would happen if you use them. However, West Bengal government has issued an advisory a few days ago not to use it in this class of patients, which is why we have stopped. But I guess you use it on an individualized basis, and the risk factors are minuscule. The side effects are minuscule compared to the benefit that you envisage from the use of this drug.
Okay, fine. So then obviously the message across would be, in a critical patients, remdesivir, if required, should be started as early as possible to have its maximum beneficial effect also. Okay, now let's move on to other section of it. And again, I would involve Dr. Guleria, sir. What is your take on use of immunomodulators? Now for this, our subject who is father who is in ICU, and what is your preference from the immunomodulators, tocilizumab, etolizumab, omalizumab, and abroad, of course, there are few other drugs which has also been tried. And what will be there are people who just give one shot, and then there are people who would prefer to repeat the dose. So on what basis will you repeat? Guleria, sir, please.
Randeep, you're on mute.
If you have evidence that the person is going on into a cytokine storm, and that would depend on the parameters that you've just shown, that the CRP, the ferritin, the LDH, and the D dimer is high, and some people would also look at the IL-6 levels, then you would be, and there is worsening of this patient's overall condition, you will have to take a risk-benefit analysis and think of giving anti-inflammatory drugs, anti-IL-6 drug. Tocilizumab can be given. We've used it quite a lot in our patients. To some extent, and this is again anecdotal, we feel it may be helpful. The data is controversial. There are some studies, there's a recent study which has shown that it may be beneficial. Some data show that it may not be beneficial. Even the study which the company itself did not show much benefit as far as the use of tocilizumab is concerned. We would give one dose. One thing to remember is that you should not monitor IL-6 levels subsequently. The IL-6 levels will actually be high or continue to rise because it doesn't decrease the IL-6 levels, and therefore I've known that some centers have actually given multiple doses of tocilizumab just looking at the IL-6 levels being high. That is something we should not do. You have to look at the clinical picture and maybe wait for at least 48 hours to see how the patient is doing and then take a call on whether you want to repeat the dose or not. Coming to etolizumab, etolizumab is an anti-CD6 drug. It has a much stronger effect as far as the immune system is concerned. It blocks a number of cytokines, including TNF-alpha. Not much experience because the data is still not strong. Most of the data is from Cuba, where this drug was popular and where it was used. There is a preprint trial which has come out as far as etolizumab is concerned from Cuba. We were involved in an RCT which was done to get its clearance from the DCGI. But we recruited very few patients, so I can't really say that that was enough to say that this drug is effective. The company says that the data did show that it was useful. I think we need more data as far as etolizumab is concerned, but it's much cheaper, but we have to be a little careful because it causes much more severe immunosuppression, including T-cell immunosuppression, and therefore may have other issues in terms of secondary bacterial and fungal infections. Right. So that is what we tend to do.
Right. In fact, the internationally, the Roche, who are the largest manufacturer of tocilizumab, they had come out with their own data and where the results have not been so encouraging. In fact, they have published also. In fact, recently, the Indian company has sent the letters, official letters to all the healthcare professionals, just dated 2 days back, about the centers which are using tocilizumab, clearly mentioning, I don't know what is the meaning of this. It states that it's not approved for COVID-19 in India. And in view of this, the physician should consider the risk and benefit of using Actimra in unapproved indications. So this is the letter which has come to, I'm sure many of you must have also received this letter coming from the Indian company also. So that is going to be a very,
Just one thing to add to what Randeep said in lines of what he said. I think you wouldn't want to give any of these MABs, any of these immunomodulators to patients who are on a ventilator. So if they are ventilated, your chances of the secondary infections Randeep spoke about, the bacterial infection, fungal infections are far higher, and you probably increase the risk of mortality. And the Roche trial that you've just mentioned actually had 40% patients on the ventilator when the drug was administered. So that might have something to do with the fact that the results weren't as positive as they are. The other thing about ETO, which we have used in about 6 or 7 patients, you have to give it very slowly. The risk of anaphylaxis with this drug seems to be pretty high experience that we've had. So they have sort of rigors, shivering, and you have to stop the drug and do it much slower, do it in 2 goes, which I think is something worth remembering for the physicians who are listening to us.
So, right. Ketan, one point I want to also add here, what I think Randeep and Raja has already very nicely dealt with this thing, that what we are seeing in the last 3 weeks is that almost 3 patients are coming post-COVID with fungal and tubercular infections. They are getting cavities in the lung, there are fluid levels there, and they are either AFP positive or they are fungal positive coming up. So this is post-tocilizumab, these patients are coming. They have already fibrosis in the lungs because I think they were in a very bad shape when Toci was given to them. But at the moment, after 2 to 3 weeks of their getting discharged from the hospital, when they are coming up as post-COVID fibrosis, but the reason of worsening is also super added infection which is coming up now, because I think the Toci has been used extensively in 4 to 6 weeks ago at that point of time. So I think we are going yet to see more and more infections post-TOSI, and it is very important for us to consider that when you are using TOSI, underlying tuberculosis and other fungal infection is a very important aspect.
In fact, you all would agree that this molecule had literally grown into the gray market, and people, and I mean the relatives, had to really go from pillar to post, paying a huge sum for getting this tocilizumab. I'm sure that must be the scenario in Calcutta or Delhi, because Bombay we had really a tough time. And I'm sure that was it. So probably it was misuse, which you said. It has to be used at for the right indication. Probably each and every one who is getting admitted to the ICU, the usage which was there, which has really created the havoc over here. Yeah, Agam, you wanted to say something.
Going by IL-6 levels. The moment IL-6 comes, in the range of 100 or nearby, plus minus 25, that TOSI was used. So I think that is an excessive overuse of TOSI in the last 2 months. And now with all this caution coming up, I'm sure we are going to deal with the side effects of TOSI.
Right. I also probably I have used it in about 50 odd patients. Thankfully it was not easily available. Otherwise, probably I would use it in more, because we did not know when to use it when we started using it. But now I think I'm quite confident we have really overused tocilizumab, and I think it is not required to that extent. Most of these patients do very well. Only a few patients go into that real cytokine storm and they require this. But then, as Sir said, it goes into ICU. The chances of them getting secondary infections are very high. And trust me, I have lost most of my patients who have gone on ventilators and required tocilizumab or have received tocilizumab. I think the sepsis or the infection probably is more in them, and I could never get them off ventilator. So I think of last, I would say about a month, I have almost not given tocilizumab to any of my patients.
Right.
I think that's very, very important, because what we've noticed is, and then we've talked to doctors across the country, that there was a huge pressure and sort of thought that this is a game changer, and I've seen people using it on day 2 and day 3.
Yes.
When you just had a rise in CRP and the ferritin or D-dimer was high, which is non-specific, and they were given tocilizumab even before they were given remdesivir or any other antiviral drug. And I think we are now seeing the effect of this, as was mentioned by Deepak. I think we have to be very, very careful, because a very small percentage of patients actually require tocilizumab. And you have to be very careful about giving it. It's something which has come into the social media, and they sometimes insist that they should be given tocilizumab. I remember one place where I think it was in Gujarat, where people waited for 2 days in front of a chemist shop just to get the vial of tocilizumab, because they felt that it will change the course of the disease as far as their patient was concerned. So I think there was a lot of sort of wrong information also in the media, and which created this extensive use of tocilizumab. It has very limited role as far as COVID-19 is concerned.
Okay. So there you have very nicely put the message across, which is so much true. So here we would come to any role of, or where do you use, how you put convalescent plasma or immunoglobulins? Agam. So your experience.
Plasma. To tell you the truth, I have not used plasma therapy directly in any of these patients, but wherever, I have been called to opine on certain patients in certain hospitals, because I visit a couple of hospitals in my area, where people have used plasma therapy. I think my experience probably is very niche, very, very early.
Anyone?
I think if used early, it may help in patients. Again, it is probably plasma means antibodies. Antibodies means viremic phase. If it is used early in course of disease, it will help. But how early? Probably no. In the sense, early phase we would try with antivirals, and in those patients where probably antivirals don't seem to have worked, there is the place for therapy. So I have still not figured out in my mind at what stage I would introduce this therapy. Yes,
Randeep has the Center for Plasma, so I think he will be able to guide us better.
Yeah, Guleria, sir.
So 2 or 3 things. One is convalescent plasma is the old therapy. It has been used for probably 100 years. It was used even in the Spanish flu pandemic, and more recently a lot of data came up when it was used in Ebola. There are 2 things as far as the convalescent plasma is concerned. The initial trials did tend to show some benefit. One small study was published in JAMA also. The subsequent trial of about 103 patients, again published in JAMA, did not really show much benefit, but it was used very late. As a matter of fact, if you look at that study, people were given convalescent plasma even after 3 weeks. it's important to remember that there are two very important caveats. Everyone who has recovered and you take his convalescent plasma may not have sufficient antibodies to be actually called convalescent plasma. You may be just giving plasma per se, which itself may also have some benefit, but you have to do an antibody titer, and that is something which we are not doing right now. We are actually just looking for the presence of antibodies, and if the antibodies are present, we assume that they are in sufficient titer and therefore it may be useful. Also, as has already been mentioned, it's useful to give it in the early stage, probably before the 7th or 8th day, before the body has itself produced antibodies. Because there is a study which is in preprint from the Netherlands, from Erasmus University, where when they looked at these patients in whom they were giving convalescent plasma, they found that they already had sufficient antibodies on day 10, and there was no point in giving them the convalescent plasma because they already had their own antibodies in sufficient concentration, which was equivalent to what they were actually giving as far as titers of the neutralizing antibodies in the convalescent plasma was concerned. Therefore, it has limited role, again useful only in the early stage, maybe given in patients who have moderate disease going on to severe disease, but I still feel we need more data. The interim analysis that we did from our center, it's a small study of around 30 patients, did not really point towards any mortality benefit, but it's a very small study of convalescent plasma, which is a randomized trial. There is a large trial that ICMR has completed of more than 400 patients who have received convalescent plasma across the country. I'm not sure, but I think it has also not showing too much of a benefit. But again, in that study, the antibody titer was not done. So we're not sure if the convalescent plasma actually was convalescent plasma or it was just plasma which was given. So we need to keep that in mind also. So I think it has limited role as of today.
Any role of immunoglobulin, sir?
Again, more data is needed. There are limited studies which have tried to show, but a lot of people feel that immunoglobulins may also be useful. There are some studies which have used it in combinations. I again don't think we have enough data to really say that this should be standard of care.
Correct. So here, what probably the trend which started was, for a bad patient, use remdesivir, no response, then use tocilizumab, no response, use convalescent plasma, but it doesn't work that way. And we have seen rather there is no benefits. And that reminds me the words from William Osler, who has very nicely put it, that the person who takes medicine must recover twice, once from the disease and once from the medicine, which is so much true when we talk of all these drugs, and all of you will agree to it. So my next question would be, Talwar sir over here. Now, role of antiplatelet versus anticoagulant, which one you'll use, what will be your choice of agent? And now again, remind you, you can't forget our family. So the father is in
both admitted patients will get low molecular weight heparin.
Okay.
The one who doesn't have much raised D dimers, I think the lady who's diabetic will get away with once a day, but the one who's in the ICU will get a therapeutic dose twice a day.
Right.
And they will continue to get till they are mobile. So obviously the one who's in the ward, hopefully she recovers and goes home, doesn't go on enoxaparin or any of the low molecular weight heparins. But the gentleman who's in the intensive care unit, till the time he becomes mobile, which may be even after discharge 1 week to 2 weeks, I would continue to use a prophylactic dose of a low molecular weight heparin. That's what we use basically.
Okay. Any role for antiplatelets?
So we are not using, so I have no idea about it. I think somebody else needs to opine on it. Raja?
So negative trial. I think there is a trial which has looked at aspirin, and I think that back as a negative trial. I don't think there's a head-to-head trial between an antiplatelet and an anticoagulant, but I would definitely hedge my bets on an anticoagulant given the nature of the disease process. About the dose and everything else, I completely agree with what Deepak said. There are a couple of trials which have looked at NOACs on discharge. So patients who've had an increasing titer of D-dimer, or patients who have had a very high single D-dimer recording of above 4,000, you might send them home on apixaban. So 2 to 6 weeks, as Deepak said, is the duration you give the NOAC for. And there are trials which show that there is a benefit, a mortality benefit, even though the trials are small and not robust. They're observational trials.
Yeah. There was one paper which was come from Mount Sinai recommendation, which had mentioned about the apixaban, which had to be continued even on an OPD base, on a outpatient department post-discharge to be continued for a prolonged period of time.
Sure.
So what is the maximum duration you are looking at for duration of therapy? Because there were few papers which had even recommended to give it up to 6 weeks, and there were few papers up to 3 months also. So anyone of you are in favor of extended prolonged usage of anticoagulant?
If I can come in.
Yes, sir.
What is usually done is that at the time of discharge, you take an assessment, a risk assessment using various scores of the risk of thromboembolic complication, deep vein thrombosis and pulmonary embolism. And based on that, you take a decision. I do agree that people who have a high D dimer, who have a high risk of DVT in terms of mobility, in terms of obesity, we should give it at least for 6 weeks and then take an assessment at that point in time whether we want to increase it or not. But 4 to 6 weeks seems to be the standard duration that we would give for most of our patients.
Okay, thank you. We will now move to again other aspect also, and again your preference for delivery of oxygen, because there are a lot of things being talked about. How are you going to deliver the talk? So Agam, would you like to take that? And
oxygen delivery would depend on level of hypoxia your patient has. All those who are mildly hypoxic would do extremely well on just nasal prongs. All you need to do is give them nasal prongs. If there is a refractory hypoxia, by refractory hypoxia I mean whenever you increase their FiO2 by 10%, if there is no corresponding rise of PO2 by 10, that is what is the definition of refractory hypoxia. You would give them different delivery systems. So there are different delivery systems available. You have a Venturi mask available. You have a reservoir bag rebreathing mask available. You have a high flow nasal cannula available. And if patient has got increased work of breathing, or if patient has got CO2 retention, or patient has got associated myocardial involvement and pulmonary edema, you would think of using a non-invasive ventilators like BiPAP, etc. Your positioning, yes, prone positioning does help. In fact, I want to add that steam inhalation does help. And I'm very fond of steam inhalation. In fact, all patients who are admitted in my hospital would get their own steam inhalation device, and they are told to do steam inhalation twice daily. In fact, I might take steam inhalation every time I finish my ICU round and come to the room. Before I start calling patient, I take steam inhalation for some time, and so I'm very fond of steam inhalation. I would give patients advice regarding proning. So whenever possible, whenever they are not full stomach, they should lie down prone, and probably that would open up the dependent portion of the lung and would improve oxygenation. Oxygen delivery depends on the kind of hypoxia they have. So you have a choice of nasal cannula versus mask versus Venturi versus reservoir bag versus high flow nasal cannula, and then if required, non-invasive ventilators. That's my take on it.
Okay. So,
can I just add one word to what Agam said? I know we have run out of time, Ketan, but even then, so slightly more, everything agreed with Agam, just a slightly more passionate message about awake proning. If there's one thing that I have learned during the pandemic, it's about awake proning. This is not something that I had known from before. We are just doing the meta-analysis on awake proning, and the results are really good. I think this is a way of keeping people out of intensive care, and in intensive care, preventing people from getting invasively mechanically ventilated. So I think it's a great thing to do. It requires some persuasion and time for the clinician. But if you manage to do it well, I think you prevent people on going on to invasive mechanical ventilation.
Right. That's a very good message.
Just to add to that, I agree with that. And I would just say that you have to really talk to the patient to make them go in for proning, both and one thing that we started doing was we would show them the oximeter and to tell them that how it's helping, because patients at times are reluctant to do proning for a long period of time. And if you just show to them that if you lie prone, your saturation has gone up, the compliance becomes much better. So as a simple thing, what you could do is to get a better compliance, keep the patient, the oximeter in front of the patient so that he sees that proning is helping. And that really helps for them to really continue to prone themselves. Otherwise, many conscious patients get a little uncomfortable as far as proning is concerned. So just wanted to add that.
Right, that is good. So I would come to Dr. Bamin Tada, sir, here. Sir, there are been the patients who are already on various drugs. And I came across, I tried to collect the literature where I found that following drugs, those who are taking or were taking, they had somehow a better outcome. So, like the first controversy came about AC inhibitor, And then subsequently, the European Society of Cardiology and American Heart Association made it very clear. And in fact, subsequently, the papers started coming, which showed the people who were hypertensive and were taking ACE inhibitor had a relatively better outcome. Same thing happened about the diabetic population, those who were on DPP-4 inhibitors or were taking gliptins, various gliptins, sitagliptin, vildagliptins, had a better outcomes, coincident, or that was the observational findings were there. Same thing happened about acid suppressive drugs. So H2 histamine HT2 receptor blockers like ranitidine and famotidine had a relatively better outcome. About lipid lowering fenofibrate had again a better outcome. Again, the diabetic drug metformin had an outcome, and even colchicine, those who were taking it had a better outcome. So, sir, what are your viewpoints about it? Dr. Bamin, Tada, please.
Well, in the beginning, I say that I'm for a long time I'm no more in a clinical, and I really apologize. I think some of you can really.
Sir, voice is not clear, sir. Yeah.
As I said before,
yeah,
that I have been away from clinics for more than 1 decade. So I think I do not have really, fair idea about.
Right. So, sir, this is what the observation. Any of the panelists want to comment on this, because that has been the various papers which are there. So, any of the panelists, yeah, Dr. Guleria, sir.
So I think there are just anecdotal reports or retrospective data which is present. There are studies which have looked at all of these. Some data which have looked at combination and shown that even H2 blockers, famotidine may be useful. Fenofibrate, metformin has been used in a large number of trials and shown that it may have some benefit. In number of things, it's also been shown to have some anti-aging effect. I know that a lot of clinicians are very fond of using colchicine because they feel it also is a immunomodulator. It may decrease the inflammation that happens, and therefore they give it as in patients with mild to moderate disease. And some physicians in various COVID centers told me that they found it to be useful. Again, this is anecdotal. I don't think there's much data as far as robust data as far as any of these is concerned. But there are anecdotal reports that they may have some benefit. I think we need more data really one way or the other to say that they are actually.
So here probably the message is not to recommend this drug, but those who are on these drugs, of course, there is no need to change over at that point of time. That is the message which can go across.
Yes,
okay.
The data doesn't show that they're harmful in any way.
Correct.
They would cause worsening of COVID-19.
Correct. Now, there are certain miscellaneous compounds which has got some role, and Agam may be tempted. The role of Mycobacterium W or nattokinase, or L-arginine, N-acetylcysteine, or pycnovate, the pine bark extract. Agam, where do you place the role of these miscellaneous compounds?
Again, as Sir said, probably not much useful. I was talking to Baba and he said even Coronil was a very good drug, from the house of manufacturer of a very large Ayurvedic drugs. So then probably, and how useful all these molecules are. I think all these molecules have some role to play in some small specific group of patients which we are yet to identify. These are all immunomodulators, but it's not like Ramban immunomodulator for every particular, immunity. It is not that it would boost every possible immunity. Now, I have used Mycobacterium W for 20 years now. 15 years ago, I used to use it for tuberculosis when we did not have clear understanding of MDR tuberculosis and XDR tuberculosis. And for us, it was only drug-sensitive tuberculosis and drug-resistant tuberculosis. So that time for drug-resistant tuberculosis, I used to use Mycobacterium W. There are some study which spoke about its use in gram-negative sepsis, and probably with COVID setting in, people started using it in COVID and have found some utility. I'm a believer of immunomodulation. I inherit my love for immunomodulation from Mohanty sir. And Mohanty sir used to use all possible immunomodulators. So I have taken myself Mycobacterium W, as a single intradermal dose, and I've got such big, large, ulcer and then probably a small abscess, and now there is a, good scar. But then, yes, it has some protective role. So if you believe in all this therapy, it works. I have not used Argin, NAC, I have not used NK, I have not used PBEs, etc. Now, pine bark extract acid have got good immunomodulative property. Have a good NAC has got good immunomodulative property. It would act on the nascent oxygen there, and we believe that corona does lead to some oxidative injury to lungs. So theoretically, yes, all these molecules may have a role, but we don't have robust data talking about it. So at this stage, I would refrain from recommending its use on a community level.
Okay, thank you. So last, I would ask Dr. Rajadhar, any role of, there has been a data which is coming up about aviptadil, vasoactive intestinal peptide, has come as RLF 100. And then there was a paper coming about the use of laser treatment in COVID-19 pneumonia. So Dr. Rajadhar, you have to comment on this aspect.
So Ketan, thanks to you, I have actually found out when you sent these questions, I had just time to read this up because I had absolutely no clue. But I mean, the data that I saw in the brief period before the meeting, I think is very preliminary. These are proof of concept studies which show that they might actually work. I don't think there are even phase 1 trials which have actually shown an effect. Human trials are being awaited. So I think it's preliminary, and like everything of what Agam said is applicable here. I don't think we are at the stage where we can even think of an indication to use it in patients with COVID-19. There's a long way to go. And I think there are lots of repurposed drugs which have been trialed in this era. These two will be done. And I think watch this space is what I would say.
Right. So that is just I wanted to bring, since there was some discussion over here, because here I would just remind me of a quote from Thomas Alva Edison, who said that I will not say I failed 1,000 times. I will say that I discovered 1,000 ways that can cause failure, and which is so much true when we were treating the patients of COVID. In fact, just to give you the summary, we lost that father who was there in ICU. The mother did very well. She came back home. And of course, the son also who was home quarantine was fine. The wife was absolutely asymptomatic. Anyway, she did well. So let's all of us pray for the world to have a better recovery, to come out from this COVID state. And I thank you all for such a fantastic participation, for so much. I thank all the panelists. And now I would request Dr. Agam Vora to take up the questions which must have come from the panel, from the audience.
There are a lot of questions, but I think due to paucity of time, I would take up only a few questions. First question is about the role of Ivermectin, and I wanted to say something, Ketan. You didn't give me a chance to talk about it. I will use this opportunity to talk about it. Ivermectin, probably it's again an old molecule, and people have tried it in various epidemics. In fact, in 2005, during malaria epidemic also, Ivermectin was greatly used. I think Dr. Tada may, add something to it, that it was used during malaria epidemic also. And I'm sure in the northeastern areas also during epidemics, Ivermectin's role was considered. 400 to 800 microgram per kilogram is what the dose is being spoken about. And we at Academy has developed a white paper, again, a consensus statement on use of Ivermectin for mild cases of, the corona infection. And we believe that if given in the dose what Sir said, 12 milligram once a day or twice a day for 3 to 5 days can be considered. In fact, we are also looking very critically at various countries where in Peru, for example, or in Bangladesh, for example, they've used it in certain areas which are hot zone. So suppose if you have a hot area and if you give it for secondary prophylaxis or probably primary prophylaxis in the area, it may help cut down probably development of COVID there, and it may be used as prophylaxis. So that is what is my thought process. Of course, all these things would require robust double-blind control studies, and we don't have time to do that. Till then, we are just reviewing literature and experiences from our neighboring countries and neighboring communities and probably using it. There are few very interesting questions, and that question is, what is there in bats which prevents them getting corona, and what is that humans we get it? We have not understood human immunity, where we are going to understand bats immunity and where we are going to understand that immunity. So probably I think that question is very interesting, but I'm sure I'm not going to bore any of the panelists with answering that question. There are questions which speak about the anticoagulant, and I think we have concluded that people are commenting that yes, there is a definite role of low molecular heparin, but due to lockdown, due to limited activity, due to limited access, and you advise your patient not to move out of the house after they are discharged from the hospital for about 5 days or 7 days. All those asymptomatic patients who are still shedding viruses, probably you advise them home quarantine. And if you have not asymptomatic, but in mild to moderate cases, probably if you have given them home quarantine and you have not admitted those patients for any of the reasons, and you have put them on low molecular heparin, it is technically very difficult for them to receive it, and there NOAC has a role. In fact, I was talking to a lot of chest physicians during this time, and a lot of us believe that it may be a thrombotic disease. So corona is a thrombotic disease. There is a hypercoagulable state, and there are some of us who believe that anticoagulation may be required in those patients for about 6 months time. You anyway advise them limited activity, so they are room bound, and in high risk patients, anticoagulation may have a role. I think most of the questions are otherwise covered. I would request, I think we would conclude session here. I take this opportunity to thank each one of you for being with us, and to tell the panel we have 1960 doctors who are currently logged in for this particular program, and then this program is also going, Akshay, it is going on Facebook Live also, no, Tada?
Yes.
So those details will get in time to come. I thank Guleria sir. I know your schedule is so busy. Every day evening you must be spending time in these meetings, and your family must be really very angry on me. So I really apologize, and I thank you for sparing your time for being with us.
Pleasure.
Dr. Talwar, thank you so much. It's always a pleasure to have you. Raja, I think we are meeting more often on web platform than probably, that we've met in last 1 year. So I thank the technology that gets us closer. Dr. Tada, it's so nice to see you, I mean, every time I see you, I remember my N number of trips that I had with you and your perfect hospitality. To tell you the house, wherever I've been to Northeast, I would always make it a point to go to Dr. Tada and Dr. Tada's house, and then probably he will take me to all those nostalgic places, the fantastic scenery and this virgin beauty which Northeast has. I think it is worth enjoying, and I think we must make it a point once this, country opens up. Sir, all of us are going to come to you, and probably we will have a small meeting there, and we would, enjoy your hospitality. Ketan, nobody can do meeting the way you did it. Your moderation is just fantastic. We thoroughly enjoyed, this program. We were very curious now what next question is going to be. What will happen to that wife, and what will happen to that husband and mother and father? You kept us all, glued up there. Akshay, thanks for giving us the platform.
Thank you.
Pratiksha, you did a good job. You coordinated very well. Mamta, fantastic. No technical hitch. The platform was just superb. And we have, a lot of questions, though a lot of questions are repeated. Akshay, what I request is you could take up those interesting questions, probably those who are not covered. And I would request, the panel to give answers, and we would get back to them. Thank you very much all. Thanks for being here. Akshay, you want to do the corporate thanks?
So, yes. Sir, thank you very much. In fact, it was a really great session. The way Arnav Goswami says that many myths are broken today. The many molecules like tocilizumab.
New myths are created.
Correct. So correct. So many myths are broken today, and it was a fantastic session. Thank you very much, Dr. Ketan. And it was the way you have made a story out of the whole things and gone to the details. So it is not just a science, but it is a story. So it was following the story. It was amazing. Thank you very much for moderating it. Thank you very much, Dr. Randeep, Guleria. I was really, not very sure that we'll be able to, able to see you in this platform. Thank you very much for making it, sir. And thank you very much. Thank you very much, sir. In fact, and thank you very much, Dr. Deepak Talvar. Sir is a very old friend of mine. We know each other from last 10, 15 years. Thank you very much for being here, sir. Thank you very much, Dr. Rajadhar, being here and accepting our invitation. Thank you very much, Dr. Tada. Yeah, thank you very much, Dr. Tada, for being here, and Dr. Mamta Jain. Sir, in fact, I have a token of appreciation. I don't want to show it now because it will take time, because you have already crossed 24 minutes more than the scheduled time frame, because it will take another 3-4 minutes. So I am not doing that. So I have a token of appreciation. So once this pandemic is over, I'll go to your place personally, and I'll hand it over to you, sir. Thank you very much. And on behalf of Delcure, I also thanks Academy of Advanced Medical Education for giving us this opportunity. Thank you very much. Thank you very much. Thank you, sir.
Thank you. Had fun.
You.
Bye, Deepak. Bye. Thank you, Dr. Talwar.
Thank you.
Thank you, Dr. Guleria. Bye, Raja.